Good morning, students. Today we are going to discuss about the joints of the lower limb, especially joints of the lower limb, that is hip joint and knee joint. These two things we are going to discuss. First, we will discuss about the hip joint. Here, all the lower limb joints, they are designed for weight bearing and weight transmission. Weight bearing and weight transmission, that is the most important function. Apart from this, they are also responsible for the movements of the body. But if you take the upper limb joints, they are designed for the movement, not for the weight bearing. Okay, that is the most important difference between the joints of the upper limb and lower limb. Okay, here first we take about the hip joint. It is the largest joint of the human body and weight bearing, and second largest weight bearing joint of the human body. Hip joint is a synovial articulation between the head of the femur and the acetabulum. Head of the femur and acetabulum. This is the head of the femur. This is the neck of the femur. This total is the upper end of the femur. You know already. Here you see this is the acetabulum. This is the acetabulum. That is in the hip bone. That is the three bones together. That is the ilium, ischium, and pubis. Three bones together, they form the acetabular notch or that depression. That is cup-shaped depression in the lateral surface of the hip bone. There is acetabulum. In between these two, that is the head of the femur and acetabulum of the hip bone, there is a joint, and there is nothing but the hip joint. There is nothing but the hip joint. What is the type of the joint? First, if you want to write about any joint, first you must write about the what type of joint, whether it is a synovial joint or it's a fibrous joint, like that. There are, you know already very well about the classification of the joints. That is, it is a multi-axial. That means you can move the hip joint in the multi-axis, and ball and socket type of synovial joint. Here the ball of the joint is head of the femur, and socket is formed by the acetabulum. So it is a ball and socket type of synovial joint. Why it is called synovial joint? Because it is lined by a synovial membrane. It is lined by synovial membrane, and it is a multi-axial. You can move the hip joint in different directions, in the different axes. That is why it is called multi-axial, and it is a socket and ball and socket type of synovial joint. Why it is ball is formed by the head of the femur, and socket is formed by the acetabulum. That is why it is called multi-axial and ball and socket type of synovial joint. That is the type of the hip joint. And hip joint is designed for stability over a wide range of movements. Stability is the main purpose of the hip joint. At the same time, it also allows a wide range of movements. Not like the shoulder joint. Not like the shoulder joint. There is some restrictions when compared with the shoulder joint. But when compared with other joints of the lower limb, it is somewhat mobile. That is, the range of movements are more. So that is the type of the joint of the hip joint. Next, descriptive planes. What are the different planes? In different planes, the movements of the hip joint are possible. That is flexion and extension. That is possible in the sagittal plane. That is the flexion extension. Okay. And next, adduction and abduction. Abduction and adduction, that is in the frontal plane. That is possible in this plane, frontal plane, and medial and lateral rotations, that is possible in the transverse plane. Transverse plane, that is and circumduction also. Circumduction also, these are all the movements, planes, descriptive planes related to the hip joint. You see here, this is the head of the femur, and this is the acetabulum of the hip bone. Together they are forming the hip joint. Next, you see, this is the head of the here. It is a sphere. It is like a sphere. That is 4/5 of the sphere. And here, this is the acetabulum. Here, acetabulum, it is formed by three bones, not the single bone. Already you know developmentally. This is the pubis, this is the ischium, and this is the ilium. That is the upper part. It is formed by the ilium, and lower posterior part is formed by the ischium, and anterior lower part is formed by the pubis. So here, there is a Y-shaped junction between three bones in the fetal life and the childhood. But in the adults, these three bones are fused and they form a single bone. That is nothing but the hip bone. Okay. Here this is the acetabulum. Here the articular surface of the acetabulum, it is not total. The total articular, the acetabular cavity is not taking part in the formation of the knee joint. That is here only the articular surface is horseshoe shape. Horseshoe shape. This part only taking part in the formation of the hip joint, because the head of the hip femur articulates with the this part of the acetabulum only. This part of the acetabulum. Okay. Next, acetabulum. You see the acetabulum here. You see this is the comma shape or horseshoe shape. Horseshoe C-shaped or horseshoe shape. And the central portion of this acetabulum, it is non-articular. The central portion of the acetabulum is non-articular. It is filled with the fat. It is filled with the fat, and this fat, it is liquid in form in the at the body temperature. It is liquid form in the at the body temperature. And here, whenever the different movements of the this hip joint, it fills the gaps whenever they are produced during different movements of the joint. That is the function of the this fat. That is a non-articular part of the fat. It is filled with the pad of fat. It is liquid form in the body temperature. Okay, that is the most important thing. And this is the articular horseshoe shaped articular surface. And here this acetabulum, it is surrounded by, that is the rim of the acetabulum. It is attached by a specialized structure that is nothing but the acetabular labrum. Acetabular labrum. Acetabular, this is the acetabular labrum. This acetabular labrum, it is made up of fibrocartilage. It is a fibrocartilaginous structure. Acetabular labrum is a fibrocartilaginous structure. It is usually it is wedge shaped. It is a wedge shaped. And here there is a gap in between the here. This is the one part of the, and then here in between these two there is a gap. This gap filled by another ligament that is called acetabular transverse acetabular ligament. Transverse acetabular ligament. What is the difference between the acetabular labrum and transverse acetabular ligament is here there is no cartilaginous part in this area, only fibrous part is there. But here it is a fibrocartilaginous. It is a fibrocartilaginous. But the transverse acetabular ligament is only fibrous. There is no cartilaginous tissue. There is no cartilaginous tissue in the transverse acetabular ligament. And this part is this is called notch. This is the acetabular notch. This acetabular notch is bridged by a fibrous structure that is nothing but the transverse acetabular ligament. Transverse acetabular ligament. Okay. Attached to this transverse acetabular ligament, there is another ligament. This is the ligament of the head of the femur, or ligamentum teres femoris. Ligamentum teres femoris is attached to the transverse acetabular ligament and acetabular notch. Transverse acetabular ligament and acetabular notch. And the base and the apex of the ligament is attached to the head of the femur. We see there. Okay. This is about the acetabulum. Next, what are the ligaments which are surrounding the joint, the hip joint? There are many ligaments. That is the first outermost covering. That is the capsular ligament. It seals the joint. It packs the joint. That is the capsular ligament. It is lined by synovial membrane. Inside this, there is a lining of the synovial membrane. And this membrane is responsible for the production of the synovial fluid. And it is responsible for the maintenance of lubrication and to prevent friction and prevent painful movements. Okay, and at the same time, it also nourishes the structures. Nourishes the some structures which are present within the joint. So that is the importance of the capsular ligament and synovial ligament. Next, acetabular labrum. Already we have seen, and attached to this there is a transverse acetabular ligament and ligament of the head of the femur. That also we have seen. And iliofemoral, fibroferal, and ischiofemoral. These are the three important ligaments that are attached to the femoral hip joint. Attached to the hip joint, that is iliofemoral. Out of this iliofemoral, it is very, very important. It is tough, strongest strongest ligaments of the body, and fibroferal and ischiofemoral. These are the total ligaments which are related with the hip joint. And next, you see here, right? It is a capsule. What are the attachments of the capsule? You see, the capsule is strong and thick. In some joints, the capsule is very thin and it is just a fibrous band. But here, the capsule is thick and strong. And medially, it is attached to the margins of the acetabulum and transverse acetabular ligament and adjacent margins of the acetabular abductor foramen. Abductor foramen. Okay, medially, the ligament is attached. This is the fibrous ligament. Medially, it is attached to the acetabular margin. It is attached to the acetabular margin. And here at the acetabular notch, there is a transverse acetabular ligament. At this level, it is attached to the transverse acetabular ligament and adjacent margins of the obturator foramen. It also adjusts to the attached to the obturator foramen. And laterally, it is attached to the intertrochanteric line. Intertrochanteric line of the femur. That is already known. The intertrochanteric line, that is a line between the greater and lesser trochanters, and just proximal to the intertrochanteric crest of the on the posterior surface. On the posterior surface, it is attached to the proximal part of the intertrochanteric crest. And the femoral neck is also attached to the femoral neck, that is intracapsular part of the femoral neck, and greater and lesser trochanters, that is extracapsular part. Greater and lesser trochanters. It also extends up to the greater and lesser trochanters. That is the extracapsular attachment of the capsular ligament of the hip joint. Next, the synovial membrane, extensive synovial membrane within the capsule. There is an extensive synovial membrane within the capsule and lines the intracapsular portion of the neck of the femur and both surfaces of the acetabular labrum, transverse ligament, and fat in acetabular fossa. Here, the fat it is also lined by, so that the acetabular fat, it is intracapsular but extra synovial. The fat which is present in the acetabular, that is in the hip joint, that is intracapsular but extra synovial. Extra synovial. That is the acetabular fat. Then it forms tubular coverings around the ligament of the head of the femur. Head of the femur, it is covered, also covered by the synovial membrane. The synovial membrane total seals the synovial, this ligament of the femur and lines the fibrous membrane of the joint. It also lines the fibrous membrane of the joint, fibrous capsule of the joint. That is the synovial membrane. Next, what is acetabular labrum? It is a fibrocartilaginous rim attached to the acetabular margin and is triangular on cross section. The labrum not only deepens the socket but grasps the femoral head tightly beyond the equator. Beyond the equator, it tightly grasps. Suppose if you take this is the head of the femur, it grasps the head of the femur in different movements. That is most important. Beyond the equator, when the fibrous capsule is disconnected, the labrum retains the head in position. That means the fibrous capsule, along with the fibrous capsule, the glenoidal labrum is also very important to retain the head of the femur in position. In traumatic posterior dislocation of the hip joint, the free margin of the labrum may be outturned or inturned. In the latter condition, that is in the interned condition, the surgical correction of the dislocation creates difficulty. That is the glenoidal labrum. You see here, this total is the glenoidal labrum. Okay, here this is the head of the femur. This is the transverse acetabular ligament. In between this is the fovea capitis. This area is called fovea capitis. This is the apex of the ligamentum femoris. Okay, ligamentum teres femoris. Okay, this is the apex. This is the base. The base is attached to the transverse acetabular ligament. Apex is attached to the fovea capitis of the femur. Fovea capitis. And this is the glenoidal labrum. Next, the transverse acetabular ligament, it extends across the acetabular notch and blends with the bases of the ligament of the head of the femur and the lower part of the fibrous capsule. And it presents a part of the labrum without cartilage cells. That is the difference between the labrum and the transverse acetabular ligament. In the transverse acetabular ligament, there is no cartilage cells, only fibrous tissue is present. Next, we see other ligament, it is iliofemoral ligament. Iliofemoral ligament, and this ligament, it is very, very important ligament. It is one of the strongest ligaments of the body. That is, this is also called ligament of Bigelow. Ligament of Bigelow, that is nothing but the iliofemoral ligament. Ligament of Bigelow is nothing but the iliofemoral ligament. This is one of the strongest ligament in the body, triangular and Y-shaped. You see, this triangular and Y-shaped. Now, this is the stem of the Y. These are the two limbs of the Y. This is Y-shaped, and apex is attached to the anterior inferior iliac spine. Already you know anterior inferior iliac spine, anterior superior iliac spine, and the anterior border of the ilium. Okay, this is the anterior inferior iliac spine. The stem of the iliofemoral ligament, it is attached to the anterior inferior iliac spine. Anterior inferior iliac spine. Then it is divided into runs downwards and laterally. And apex is attached, and the base is intertrochanteric line. This is the lesser trochanter, this is the greater trochanter, then this is the intertrochanteric line. The base of the ligament is attached to the intertrochanteric line. Intertrochanteric line. This is the one stem, this is another stem. Okay, in between these two, there is a small gap. There is a small gap. It is lined by a membrane. This gap is filled by a membrane. Okay, and reinforces the joint anteriorly. It supports the joint, it reinforces the joint in the anterior, from the anterior aspect, and here it prevents the overextension. Overextension, that is very, very important. The prevention of the overextension is very, very important. If you want to stand, this ligament must be intact, and it supports our body for standing purpose. Otherwise, you may fall down backwards. You may fall backwards. That is why the iliofemoral ligament. It is the strongest ligament one of the strongest ligaments of the body, and it prevents the backward flow or extension of the hip joint. Extension of the hip joint. That is why this ligament, in your examination point of view, also iliofemoral ligament is very important. Very important when compared with other two ligaments, that is pubofemoral and ischiofemoral ligaments. This is the thick ligament, and it is a strong ligament. It is a strong ligament, and prevents trunk from falling backwards by standing. That is the most important function of the iliofemoral ligament. Iliofemoral ligament. Because in standing position, usually the line of gravity goes behind the hip joint, behind the head of the femur. That is why there is a tendency to fall backwards, but it is prevented with the help of the iliofemoral ligament. Okay, this is the iliofemoral. Next, coming to another ligament, that is pubofemoral ligament. Okay, see here, this is the pubis bone, and this is the femur, and in between these two there is a green one. This green one, it is nothing but the pubofemoral ligament. Supports the joint inferomedial. In the inferomedial part of the joint, it is supporting, and it is triangular in shape. It is also triangular in shape, and superiorly attached to the iliopubic eminence and obturator crest. This is the iliopubic eminence, and here this is the obturator crest. It is attached to the obturator crest and iliopubic eminence. Superiorly and inferiorly merges with the capsule and lower band of the iliofemoral ligaments. Here this is the lower band, this is the upper band of the iliofemoral ligaments. Here it blends with the inferior band of the iliofemoral ligament. At the same time, it also blends with the capsular ligament of the hip joint. It limits the extension and abduction. Extension, backward movement, and abduction, lateral movement. It restricts. Whenever if you abduct the bone like femur like this, it is stretched and it restricts the abduction movement. These are the two most important functions of the pubofemoral ligament. Next, coming to the other ligament, that is ischiofemoral ligament. Ischiofemoral ligament, it reinforces the posterior aspect of the fibrous membrane. That is fibrous capsule. It is strengthened with the help of the ischiofemoral ligament in the posterior aspect of the hip joint. Medially, it is attached to the ischium. This is the ischium bone, and just posterior inferior to the acetabulum. Just here in this area there is acetabulum, and this is the posterior-inferior part of the acetabulum. That is the area for the attachment of the ischiofemoral ligament. That is the medial part of the ischiofemoral ligament. And laterally, it attached to the greater trochanter deep to the iliofemoral ligament. It is attached to the greater trochanter and limits the extension of the joint. Also, limits the extension of the joint. Here you see another ligament, that is a ligamentum teres femoris. Ligamentum teres femoris. Here this small band, it is nothing but the ligamentum teres femoris. And this part is called fovea capitis. Capitis means head. Here fovea, in the head there is a depression, that is called fovea capitis. And this is the ligamentum teres femoris. And here the round ligament of the femur. Ligament of head of the femur. This is also called round ligament of the femur. Ligament of the head of the femur, ligamentum teres femoris. These are all the same, one and the same. This is triangular and flat. This is triangular and flat. And flattened band apex to the, attached to the fovea capitis and base to the acetabular notch and transverse acetabular. Acetabular already we have seen is attached to the acetabular notch and transverse acetabular notch. Encircled by synovial membrane. It is covered by synovial membrane and transmits artery to the head of the femur from the acetabular branch of the medial circumflex femoral artery. Medial circumflex and femoral artery. Here, this is the one of the most important function of the head of the ligament of the teres. Ligament of the teres, because it transmits the blood vessels from the medial circumflex and femoral arteries, and it is one of the arteries supplies to the head of the femur. And okay, that is the most important function. Next, what are the relations of the joint? What are the relations of the joint? That is anteriorly iliopsoas, pectineus, and rectus femoris. Anteriorly iliopsoas, pectineus, and rectus femoris. Rectus femoris muscles. Rectus femoris muscles. And next, posteriorly, that is the obturator internus, the gemini, and quadratus femoris muscles separate the joint from the sciatic nerve. Here, these are the posterior relations. That is posterior relations. Okay, this is the obturator internus with the gemini. This is the piriformis. This is the quadratus femoris. Next, superiorly, piriformis and gluteus minimus. Piriformis and gluteus minimus in the superior part. Here, this is the piriformis. This is the gluteus minimus in the superior part. And inferiorly by the obturator internus tendon. Obturator internus tendon. Inferior. This is the obturator internus and obturator externus and tendon. Okay. Next, what are the nerve supply to the hip joint? That is femoral nerve. Here, Hinton's law already know. The nerve supplying the joint also supplies the muscles moving the joint and the skin covering the insertion of these muscles. Skin covering the insertion of this. This is the Hilton's law of nerves. Here, the femoral nerve, anterior diagonal obturator nerve, nerve to rectus femoris, nerve to quadratus femoris, sciatic nerve, superior gluteal nerve. These are all the nerves supplying to the hip joint. And the femoral nerve not only supplies the hip joint via intermediate and cutaneous nerves of the thigh, also supplies the skin of the front and medial side of the thigh. That is, follows the Hilton's law. And posterior division of the obturator nerve supplies both the hip joint and knee joint. Therefore, sometimes there is a referred pain in the knee joint. Suppose if you see in some individual, if there is a pathology in the hip joint, the pain may radiate to the knee joint, also because it is the obturator nerve, it comes out from the pelvis. In some occasions, in the pelvic pathology also, there is a chances for the compression of the obturator nerve, and it may also produce referred pain in the knee joint, especially in females. Due to pelvic, that is ovarian pathology or uterine pathology, it may also affect the obturator nerve, compresses the obturator nerve, and because of this reason, there may be referred pain in the knee joint, chronic referred pain without concern. That is structural deformities. We have to suspect that uterine pathology or some pelvic pathology. We have to rule out the pelvic pathology. That is the important clinical point. Next, coming to the arterial supply, the blood vessels which are supplying to the hip joint is also very, very important. Here on the capsule, there are two types of pipe. That is a fibrous capsule. It is covering the joint. That is having two types of fibers. That is orbicular fibers or circular fibers. Zona orbicularis, and another one reticular fibers. Reticular fibers. The orbicular fibers and reticular fibers, especially along the reticular fibers, the blood vessels from the ascending branch of the left circumflex femoral artery and right circumflex femoral artery, and branches from surrounding arteries. Surrounding arteries, that is a superior gluteal arteries, and there is a branch from the, there is a abductor artery, that is the head of the. Here, these are all the blood vessels which are supplying to the head of the femur and neck of the femur. Here, what is the clinical importance of this one is, suppose if there is a fracture of the neck of the femur, especially the neck of the femur fractures are more common in elderly female patients because of hormonal imbalance, that is changes, that it leads to osteoporosis, and there is a decrease in the muscle mass, and there is a decrease in the content of the fat also. If they fall on the back, especially it is more common in the bathrooms. That is fall in the bathroom. That is the most common cause for the fracture of the neck of the femur. Suppose if the fracture of the neck of the femur at this level, it may cause damage to the blood vessels also, which are supplying to the head and neck of the intracapsular part of the head and neck of the femur, and it may lead to avascular necrosis. Avascular necrosis. That is also one of the complication of this head of the neck of the femur fracture. Neck of the femur fracture. In that occasion, we have to go for the excision of the head of the femur and go for the artificial head. That is the prosthesis. We go for the prosthesis, implantation of the prosthesis. That is also one of the most important thing related with the arterial supply of the hip joint. And apart from this, tuberculosis of the hip joint is also possible, especially that is a postero-inferior part. Postero-inferior part of the is neck of the femur, that is the Beckhoff's triangle. That area is called Beckhoff's triangle. That is the location for the starting of the tuberculosis of the hip joint. Tuberculosis of the hip joint. And at the same time, you see, this angle is called neck shaft angle. Neck shaft angle. Usually it is about 125 degrees. 125 degrees in the adults. And in the children, it is about 160 degrees. 160 degrees. Suppose there is an increase in the neck shaft angle, sometimes there may be decrease in the neck shaft angle. If there is an increase in the neck shaft angle, that is called coxa vara. And if there is a decrease in the neck shaft angle, that is called coxa vara. If there is increase in the neck shaft angle, that is called coxa valga. Coxa valga. That is it leads to its own problems with the movement of the joint. Movements of the joint. And these are all the some important points related to the hip joint. And movements that is possible at the hip joint, that is flexion, this is the extension, and this is the abduction, adduction, and this is the abduction. And this is the lateral rotation, this is the medial rotation. These are all the possible movements at the hip joint. Next, what are the muscles which are producing the movements? That is the flexion, iliopsoas, sartorius, rectus femoris, tensor fascia, and extension by the gluteus maximus, semitendinosus, semimembranosus, biceps femoris. And abduction by the gluteus medius, minimus, tensor fascia lata with the flexion of the hip. And adduction, that is peculius, adductor longus, brevis, and magnus, and gracilis. The medial rotation with the help of the gluteus medius, minimus, and tensor fascia lata. And lateral rotation with the help of the abductor internus and externus, gemellus superior and inferior, quadratus femoris, piriformis, and posterior fibers of the gluteus medius, minimus, and superior fibers of the gluteus maximus. These are all the movements which are possible at the hip joint. Next, coming to the knee joint. Okay, knee joint, it is a joint, the largest joint of the and most complicated joint in the body. Most complicated joint in the body. That is here. This is the largest weight-bearing joint. Largest weight-bearing joint. It is modified variety of hinge synovial joint. Hinge variety of synovial joint because it allows some rotatory movements besides flexion and extension. Suppose if it allows only flexion and extension, we call it as hinge joint. But it also allows somewhat rotatory movements. That is why it is called modified hinge variety of synovial joint. Modified hinge variety of synovial joint. Okay. What is the type of the joint? It is a modified hinge variety of synovial joint. It is a complex and complicated joint because there are many articular surfaces, many ligaments, many structures within the joint. That is why it is a complex joint. Complex. It consists of three joints. Actually, the knee joint is not a single joint. It is a combination of three joints. It's a combination of three joints. First one is the medial condylar joint, that is between the medial condyle of the femur and medial condyle of the tibia, and lateral condylar joint between the lateral condyle of the tibia and lateral condyle of the femur, and patellofemoral joint, that is between the patella and the patella surface of the femur. Okay, that is that patella surface of the femur also called trochlea. Okay, this is the combination of three joints, that is nothing but the knee joint. First we see patellofemoral joint. The patellofemoral joint is composed of the superior suprapatellar notch, pouch of the suprapatellar pouch, the patella bone, trochlea, medial and lateral femoral condyles, and medial and lateral patellofemoral ligaments. This is the one joint. And the patella is one of the sesamoid bones, already you know. It has medial and lateral facets that articulate with the respective condyles. Already we had seen the patella, the articular surface of the patella, it is divided into 7 parts. 7 parts with the help of the 2 vertical and 2 transverse segments, that is the partitions. It is divided into 7 segments. And these 7 segments, centrally there is an apex of the bone that sits in the trochlea. This part of the bone sits in the trochlea. On both sides, they articulate with the femoral condyles. Next, in extension, the distal portion of the lateral articular, that is patella facet, articulates with the lateral femoral condyle, but medial patellar facet barely articulates with the medial femoral condyle until the complete flexion is approached. That means in full flexion only the medial condyle articulates with the medial articular surface of the patella articulates with the medial femoral condyle, but the lateral femoral condyle, the particular patellar surface, they articulate easy. Okay, the medial and lateral patellofemoral ligaments are thickenings of the medial and lateral retinaculum, medial and lateral retinaculum respectively. They originate centrally on the patella and insert to the medial and lateral epicondyles of the femur. Next, to tibiofemoral joint. Tibiofemoral joint, that is femoral condyles. That is the lateral condyle. This is the lateral condyle. This is the medial condyle. The lateral condyle is smaller in radius of curvature, smaller in all dimensions, extends more anteriorly, and medial condyle larger in radius, extends more distally, the intercondylar notch. This is the intercondylar notch. Next to the tibial plateau, that is the tibial side of the articular surfaces, that is a medial plateau, that is a greater surface area, concave and circular. Medial part is greater surface area, concave and circular, and the intercondylar area. This is the intercondylar eminence or elevation. And lateral plateau is smaller surface area, convex and oval in shape. This is the lateral articular part of the tibial condyle. And what are the joints? What are the ligaments which are which are related with the knee joint? That is also very, very important. First, the joint total, it is covered by a synovial, that is a capsular ligament, and inside it is lined by synovial membrane. The ligamentum patellae, that is next is the tibial and fibular collateral ligaments, oblique popliteal ligament, arcuate ligaments, anterior and posterior cruciate ligaments, coronary ligaments, transverse ligament, and meniscofemoral ligaments, and medial and lateral menisci. These are all the structures which are related with the knee joint. First, you see about the capsular joint. Capsular ligament attached to the margins of the articular surfaces and surrounds the sides and posterior aspect of the knee joint. On the front, the joint capsule is absent, permitting the synovial membrane to pouch outwards beneath the quadratus femoris tendon and forming the suprapatellar bursa. Suprapatellar bursa is nothing but the outward protrusion of the synovial membrane or pouch of the synovial membrane of the knee joint. On each side of the patella, the capsule is strengthened by the expansions from the tendons of the vastus medialis and lateralis. We call it as retinaculum. Okay. And next, behind the joint, the capsule is strengthened with the help of the expansion of the semimembranosus, that is nothing but the oblique popliteal ligament. Oblique popliteal ligament is nothing but the expansion from the semi-membranosus attachment tendon. Okay, and an opening in the capsule behind the lateral tibial condyle permits the tendon of the popliteus to emerge. The popliteus muscle takes intracapsular origin, and it comes out to the opening in the posterior part of the capsular. Posterior part of the capsular. Here you see, this is the synovial membrane. Okay, these are all the bursa which are related with the new joint. That is the subcutaneous prepatellar bursa, infrapatellar bursa, and deep infrapatellar bursa. This is the synovial membrane, and it extends behind. This is the tendon of the quadriceps femoris. So here, this is the suprapatellar bursa, and these are all the remaining bursa. You see. Next, the synovial membrane. The synovial membrane of the knee joint attaches to the margins of the articular surfaces and the superior and inferior outer margins of the menisci. They are also attached to the menisci. It lines the joint capsule except the posteriorly where the cruciate ligaments are found. Here, the synovial membrane is the cruciate ligaments. They are intracapsular about extra synovial. Cruciate ligaments are intracapsular but extra synovial. That is a very important point. In front, it is absent from the patella. The two cruciate ligaments which attach in the intracondylar region of the tibia below and the intracondylar fossa of the femur above are outside the articular cavity but enclosed by within the fibrous membrane of the knee joint. Posteriorly, the synovial membrane reflects off the fibrous membrane of the joint capsule on either side of the posterior cruciate ligaments and loops forwards and around the ligaments, thereby excluding them from the articular cavity. Okay, you see, these are the two cruciate ligaments. This is the glenoidal labrum, and these are the menisci. The blue colored one is the menisci. These are the menisci. Okay, and this is the glenoidal labrum. Next, the coronary ligaments. The fibrous capsule is attached to the periphery of the menisci. You see here, this is the fibrous capsule. It is attached to the periphery of the menisci with the help of the coronary ligaments. Connects the periphery of the menisci to the tibia. They are the portion of the capsule that is stressed in rotatory movements of the knee joint. Next, cruciate ligaments. These are the very, very important ligaments. They may ask for the short answer. Cruciate ligaments. These ligaments, there are two, right? There is two cruciate ligaments, that is right and left. Okay, cruciate ligament, anterior, sorry, not right and left, anterior, posterior cruciate ligaments. This is very thick, strong fibrous band. Direct bands of the union between the femur and tibia. That is very, very important. Now, directly, this is the connection between the tibia and femur. That is the cruciate ligaments. Represents the collateral ligaments of the original femorotibial ligaments. These are femorotibial ligaments, the collateral ligaments of the original femorotibial ligaments. That is nothing but the form of cruciate ligaments. Maintain the anteroposterior stability of the joint and named according to the attachment to the tibia. The cruciate ligaments, that is the anterior posterior cruciate ligaments, they are named according to the attachment of the tibia, not to the femur. Okay. If it is one ligament, it is attached anteriorly to the tibia, that is called anterior cruciate, and the posterior part of the tibia, that is called posterior cruciate. Supplied by vessels and nerves which pierce the oblique popliteal ligament. The vessels and nerves which are piercing the joint capsule through the oblique popliteal ligament in the posterior aspect. These vessels and nerves, they are supplying to the cruciate ligaments. Okay, you see. These are the cruciate ligaments. This is the posterior cruciate ligament. Okay, this is the anterior cruciate ligament. Because it is attached to the tibia in the anterior part and it is attached to the tibia in the posterior part. This is the posterior cruciate attachment. This is the anterior cruciate ligament. That is why it is called anterior cruciate ligament and this is called posterior cruciate. Okay, these are the ligaments. Next, to anterior cruciate ligament in detail. The anterior cruciate ligament attached to the facet on the anterior part of the intercondylar area of the tibia and ascends posteriorly to attach the facet on the back of the lateral wall of the intercondylar fossa. So the anterior cruciate ligament goes from anterior to posterior like this. You see, it goes from anterior to posterior in the posterior direction. Then it will attach to the femur, that is intercondylar fossa, that is the lateral wall of the intercondylar fossa of the femur. And the anterior cruciate ligament crosses lateral to the posterior cruciate ligament as they pass through the intercondylar region. By passing the intercondylar region, suppose if you see, this is the posterior cruciate, this is the anterior cruciate. It goes like this. The anterior cruciate ligament goes posteriorly like this, posterior, okay, laterally, and the posterior cruciate ligament starts in the posterior, then it comes anteriorly, it is attached to the medial wall of the intercondylar region. Okay, the anterior cruciate ligament prevents anterior displacement of the tibia relative to the femur. Here it prevents the anterior displacement of the tibia. It is stored during knee extension. Extension of the knee, during extension of the knee, it becomes stored. And posterior cruciate ligament, the posterior cruciate ligament attaches to the posterior aspect of the intercondylar area of the tibia and ascends anteriorly to attach to the medial wall of the intercondylar fossa of the femur. And posterior cruciate ligament restricts the posterior displacement of the tibia, and it is stored during flexion of the knee joint. During flexion of the knee joint. That is the difference between the anterior and posterior cruciate ligaments. And next is the medial collateral ligament or tibial collateral ligament. It is also called tibial collateral ligament. Medial collateral ligament or tibial collateral ligament. And it is attached superiorly to the medial epicondyle of the femur, just below the adductor tubercle, and inferiorly divides into superficial and deep bands. The superficial part it is attached to the upper third of the tibia as far down as the tibial tuberosity. Okay, it attaches up to this area, superficial band. And the deep portion, which is short and fuses with the capsule of the and with the medial meniscus. Here the short part only up to this level. The deep part is only up to this level. Fuses with the capsule of the knee joint and the meniscus, the medial meniscus. And but the superficial part it reaches up to the this level. That is the next. Bursa usually separates the two parts. That is medial cruciate ligament, medial collateral ligament. Tightens the extension. This tightens during extension of the joint, and the valgus stress put the strain on the. Here, suppose if there is a stress on the medial side, from the medial side, there is hit on the medial side of the knee joint, make lateral side of the knee joint. It may cause a stretching of the medial collateral. Next, lateral collateral or fibular collateral ligament. The superiorly it is attached to the lateral condyle of the femur just above the popliteal groove. And inferiorly it embraces the tendon of the biceps femoris and attached to the head of the fibula in front of the apex. It is attached to the head of the fibula in front of the apex, and separated from the lateral meniscus by popliteal tendon and fibrous capsule. It is separated from the lateral meniscus. Tightest in extension, that is 0 to 30 degrees extension. During extension, and becomes loose when flexion more than 30 degrees. Primary restraint at the varus, that is if there is an injury at the from the medial side, and secondary restraint at ER distribution, that is the external rotation and the posterior translation. Next, oblique popliteal ligament. This is the oblique popliteal ligament. This oblique popliteal ligament, it is nothing but expansion of the semimembranosus tendon, and it closes the insertion of the tibia. And oblique popliteal ligament passes upwards and laterally, and fuses with the fibula if present. If there is a fibula, already know that is a fibula. What is fibula? Patella is a sesamoid bone. It is developed in the tendon. If there is a development of the other sesamoid bone in the posterior part of the knee joint, that bone is called, that sesamoid bone is called fibula. This bone is called fibula. If the fibula bone is present, this ligament is attached to the fibula. Okay, here the important point regarding the patella is, if there is a fracture of the patella, there is no union of the patella, because it is a sesamoid bone. The sesamoid bones, they are not covered by the periosteum. And the periosteum is responsible for the fracture union. Fracture union. Suppose if there is a fracture of the sesamoid bones, patella or patella, there is no formation of union of bones because there is no there is periosteum. Okay, because of this reason, we have to fix the screws or you have to wire the patella to keep in a single bone. That is very important clinical point. Next, these are all the points related with the posterior cruciate ligament, posterior oblique popliteal ligament, oblique popliteal ligament, and it lands in the posterior surface of the capsule above the lateral femoral condyle and pierced by middle genicular vessels and nerves. Okay, these are the important nerves and vessels, middle genicular vessels and nerves. These are the nerves and vessels that are supplying to the cruciate ligaments. Cruciate ligament by piercing the oblique popliteal ligament. This is the site for the piercing of this middle genicular vessels and nerves, and they go into the joint and they supply to the cruciate ligaments. Anterior and posterior cruciate ligaments, they are supplied by the middle genicular nerves and vessels. Middle genicular nerve and vessels. The branch from the posterior division of the obturator nerve pierces the ligament and supplies the cruciate ligaments to the knee joint and pain from the pelvic peritoneum. Okay, already I discussed. Okay, here if there is a pain in the pelvis, there may be chances for the referred pain in the knee joint because it is supplied by the obturator nerve. It is supplied by the obturator nerve branches. That is, we are supplying to the cruciate ligaments by piercing the oblique popliteal ligaments. Okay, that is why the obturator nerve pathology may lead to referred pain in the knee joint. That is important clinical point. And the popliteal artery lies on it. Just popliteal artery passes through this like this. Okay, and strengthens the posterior portion of the capsule and prevents extreme lateral rotation. That is, what is the function of the oblique popliteal ligament? It prevents the extreme rotation and it strengthens the posterior part of the capsule of the joint. So strengthens the posterior part of the capsule of the joint. That is the importance of the oblique popliteal. Next, another ligaments, that is menisci. These are the very important. The menisci are two fibrocartilaginous structures, crescent-shaped attached ends to the tibia, deepens the articular surface of the tibia. What is the function of the what is the most important function of this menisci? It deepens the article, because if you see the bones, articular surface is almost flat, but here with the help of this menisci, the articular surfaces of the tibia, they becomes deepened, and here at the same time it is also having its own function. We see they wedge shaped on cross section. They are the, to take the section, they are using here. This is the wedge shaped section. In the cross section, it is wedge shaped, and it is outer and border is thick, convex, fixed, and vascular. You see, this is the outer border. It is thick, fixed, and convex. Okay, and it is vascular. It is receiving directly blood vessels. Blood vessels are supplying to this outer part of this meniscus, and but in the inner portion, the inner border is thin, concave, free, avascular. This inner portion is avascular, and it is nourished by synovial fluid. That is also another important function of the synovial fluid. And this thin portion of the menisci, they are nourished by the synovial fluid. But the outer convex and fixed part, the thick part, it is receiving direct blood vessels from the knee joint. Okay, that is the important point related with this menisci. And they are intracapsular and intrasynovial. That is the most important point. These menisci are intracapsular, intrasynovial. Intracapsular and intrasynovial. Next, there are two menisci. That is, it has two ends, two borders, and two surfaces. This is the anterior end, posterior end. Okay, this is the anterior end, this is the posterior end, and two borders, outer border, inner border, superior surface, inferior surface. Flexion and extension takes place at the upper surface of the menisci. Flexion extension at the upper surface of the menisci, and rotation occurs between the lower surface of the menisci and the tibia. That is also very important. Suppose if you are flexing the knee joint means it occurs at the superior surface of the menisci. That means menisco-femoral compartment. Menisco-femoral compartment of the knee joint. And if we get a rotation of the joint, the rotation occurs between the lower surface of the menisci and the tibia. Lower surface of the menisci and tibia. And the medial meniscus, it is relatively mobile. It is a C-shaped, semicircular, fibrocartilaginous disc, peripheral margin adhered to the tibial collateral ligament and more liable to injury. This is the most liable to the injury. It is medial meniscus. And lateral meniscus, it is more round, circular in shape, and it is posterior end of the meniscus. It attached with the femur through a two meniscofemoral ligaments. The tendon of the popliteus and fibrous capsule separate it from the lateral cruciate ligament. Okay, next, the mobility of the posterior end is controlled by popliteus and two meniscofemoral ligaments. Okay, these are the two menisci. This is the medial meniscus. This is the lateral meniscus. Next, functions of the meniscus. That is also important. The shock absorbers. They act like a shock absorbers and redistributes the synovial fluid. Redistributes the forces which are produced on the joint, and it spreads the synovial fluid. And minimal effect on stability. On rotation, menisci move with the femur. Suppose if there is movement, the menisci are moving along with the femur, and lateral movement is lateral meniscus moves 20 to 24 millimeters, but medial meniscus, it is less movement, that is 10 to 15 millimeters. Lateral meniscus bears more load. That is another ligament, that is a transverse ligament, that is in between the anterior ends of the, it connects the anterior ends of the medial and lateral meniscus. This is the transverse ligament. Next is the meniscofemoral ligaments. Meniscofemoral ligament, from the meniscus to the femur, this is the posterior meniscofemoral ligament, and there is another ligament, there is anterior meniscofemoral ligaments. These meniscofemoral ligaments, the anterior meniscofemoral ligaments, is also called Humphrey's ligament, is attached to the lateral aspect of the medial femoral condyle in front of the posterior cruciate ligament. Next, the posterior meniscofemoral ligaments, they are called Wisberg's ligaments, and it is attached to the posterior cruciate ligament. And what are the muscles producing the movements, different movements? That is extension movement, that is quadriceps femoris and assisted by the tensor fasciae later, flexion, primovers, semimembranosus, semitendinosus, biceps femoris, and the flexion is initiated by popliteus by unlocking the knee joint. If you want to flex the knee joint, first you must unlock the joint from the locking position. What is unlocking? What is locking? We see. Okay, next, assisted by sartorius, gracilis, both heads of the gastrocnemius and plantaris. The medial rotation by the semimembranosus, semitendinosus, popliteus, sartorius, and gracilis, and lateral rotation by the biceps femoris, and relations of the joint. That is in front, quadriceps femoris, and anterior medially by the medial patellar retinaculum, anterolaterally by the lateral paternal reticulum and iliotibial tract, and posteromedial by the sartorius, gracilis, semitendinosus, and semimembranosus, and posterolaterally by the tendon of the biceps femoris and common peroneal nerve. And you see, these are all the ligaments, relations of the knee joint. Anteriorly by the, that is tendon of the quadriceps femoris, and these are all the anterolateral, posterolateral, anteromedial, posteromedial. Okay, like that, these are all the structures and most posterior relations. Behind the popliteal vessels, tibial nerve, both head of the gastrocnemius and plantaris, they are in the posterior part. And another important structures which are related with the knee joint is bursa. These are also very important clinically. In front, there are 4 bursa. That is subcutaneous prepatellar bursa. It intervenes between the skin and the anterior surface of the patella. Sometimes the bursa is swollen in housemaids due to washing the floors by adapting to knee down position. Hence, this is called housemaids bursitis. Housemaids bursa. If there is inflammation of this bursa, we call it as housemaids bursitis. You see, this is the subcutaneous prepatellar bursa. So, if it is inflamed, we call it as housemaids bursitis. Next, subcutaneous infrapatellar bursa. It intervenes between the skin and the tubercle of the tibia, where ligamentum patella is attached. This bursa is sometimes swollen in persons during praying in the kneel down position with the trunk upright. Hence, this is called clergyman's bursa. Here, if there is inflammation of this, that is a prayer, especially the Muslims and Christians, they pray God by kneel down. Okay, in that occasion, interact body. Okay, in that occasion, there is chances for the pressure over this bursa, and it leads to clergyman's bursitis. Clergyman's bursitis. That is also another bursa. And deep infrapatellar bursa, it lies behind the patellar ligament in the interval between the femur and the anterior surface of the upper part of the tibia. Okay, and suprapatellar bursa, it intervenes between the quadriceps femoris tendon and the lower end of the femur and communicates with the joint. Okay, these are all the important bursa and in the anterior part. And the posterior part also, there are some bursa, that is popliteal bursa, semitendinous bursa, tendons of the insertion of the biceps femoris, answer, serine bursa, and beneath the origin of the lateral head of the gastrocnemius also there is small bursa, and beneath the origin of the medial head of the gastrocnemius. These are all the total 10 bursa are present around the knee joint. 10 bursa are present around the knee joint. Okay, these are all the blue colored one, they are nothing but the bursa of the knee joint. Okay. Next, coming to the arterial supply, the blood vessels which are supplying to the knee joint, that is a descending genicular, descending branch of the lateral circumflex femoral, and popliteal artery branches, that is from the superior and inferior medial genicular, middle genicular, superior and inferior lateral genicular, anterior tibial artery, anterior posterior tibial branches, recurrent branches, from the posterior tibial artery, circumflex fibula. These are all the blood vessels which are supplying to the knee joint. And nerves, that is a femoral nerve, it gives strings to the nerves, that is a three vastus, that is vastus medialis, lateralis, and intermedius. All the nerves which are also supplying to the joint. From the tibial nerve, superior and inferior medial genicular nerve, and middle genicular nerve, and common peroneal nerve, and superior and inferior lateral genicular nerve, recurrent genicular nerve. These are also from the common peroneal nerve, and the nerves which are coming from the obturator nerve, that is the genicular branches from the posterior division, that is also supplying to the knee joint. Okay, and next last point, that is locking and unlocking. What is locking and what is unlocking? This is a terminal stage of the flexion, full extension of the knee joint. The tibia is laterally rotated. Femur is medially rotated. Tibia is laterally rotated. Femur is medially rotated. This rotatory movement locks the joint, which means that the joint cannot be flexed unless it is unlocked by the reverse rotation. That is why it is called locking of the knee joint. This rotation movement looks like a locks the joint, and it means the joint cannot be flexed unless it is unlocked by the reverse rotation. Okay, that is tibia rotates laterally and femur rotates medially. This is called locking position. In full extension with the locked knee, all the ligaments are stretched. The joint is stable except the ligamentum patella. Except the ligamentum patella, it is relaxed. The ligamentum patella is the anterior ligament of the knee joint. It is relaxed. Remaining all ligaments are stretched. Produced by biceps femoris muscle, the only lateral rotator. It is produced by the next unlocking of the knee joint. Unlocking of the knee during flexion of knee. During flexion, if you want to initiate the flexion of the knee, it is first necessary to untwist and reduce tension with the major ligaments of the knee in order to prevent their repeated excessive stretching. And that is a contraction to the popliteus muscle. First, there is a contraction of the popliteus muscle, and then it is followed by lateral rotation of the femur on the tibia and pulls the lateral meniscus posteriorly out of the way of the rotating lateral femoral condyle. Once the femur has laterally rotated, the knee is said to be unlocked and the flexion can proceed. Okay, that is the unlocking. That is the locking and unlocking. This locking and unlocking of knee joint is also very, very important shortcuts. Okay, and then the ankle joint, that is one ligament is deltoid ligament. You will study. There is no time, lack of time, unable to discuss. Okay, and that is the locking and unlocking. The locking and unlocking is also very important. And ligaments of the joint, knee joint, and articular surface of the knee joint. Okay, everything. Knee joint, this is the most commonly asked question for the first year because this is the most common clinical condition. It is a knee joint replacements, osteoarthritis of the knee joint, and patella fractures. Okay, these are all under ligamental tears, especially cruciate ligaments. Anterior cruciate ligament, posterior cruciate ligament, or sometimes there may be patellar, that is a tibial collateral ligament, and fibular collateral ligaments, they may tear. Because of this reason, this is the most commonly injured joint during road traffic accidents and different working places. That is why you must, it is very, very important. Knee joint. Okay, you go through the thoroughly knee joint. Whenever you come, if you need doubts, we discuss that. Okay, thank you.